I'm Amos, an international starts badly. I'm internal medicine specialist, and I am affiliated to the Sackler Faculty of Medicine at the Tel Aviv University, Israel. And I'm also a current IMS board member. Thank you all for joining this IMS webinar on breast cancer. I am delighted we have been able to stream this webinar to a large Chinese audience today. And on behalf of the IMS, I warmly welcome you. I would like to also make you aware that our Impart educational course is now available in Chinese, and we will have information on how to register available at the end of this webinar. I also want to apologize for two things. First is my voice. I have chronic hoarseness because of some problem at my vocal cords. And secondly, I am at home. It's in the middle of Tel Aviv city. There might be some noise from outside and also barking of my dog. So if it happens, please excuse me. Our speakers today, the first one is Professor Michael Baum. He will talk to screen or not to screen. And the second would be by Professor Petra Stute, and she will talk about HRT and breast cancer risk. Next slide, please. This webinar was supported by an unrestricted educational grant from Bessen's Healthcare. Bessen's Healthcare had no role in this selection of topics, selection of speakers, and have not vetted or reviewed the content of the speakers' presentations. Next. I will talk slowly so that the interpreters to Chinese could have an easier job. Breast cancer ranks first among non-skin cancers in women. It is age-related, which makes early detection and treatment a worthy strategy. Except for age, there are several other risk factors for breast cancer, such as BRCA mutation, family history, reproductive factors, medications, obesity, lifestyle, and others. Next slide, please. Since the start of mammography screening, the incidence of breast cancer increased significantly, raising the question when to start and whether we should embrace population-based programs or personalized, risk-adapted programs. Also, screening might be associated with false positive findings and with related unjustified treatments, much like the PSA screening for prostate cancer in men. Next slide. So here you see what I just said, that overdiagnosis of breast cancer is estimated to occur in up to 30% of all screen-detected breast cancers. Professor Michael Baum will discuss the pros and cons of screening. Professor Baum is a British oncologist. He has been president of the British Oncology Association, the European Breast Cancer Conference, and chairman of the Psychosocial Committee of the National Cancer Research Institute. Professor Baum was awarded several times for his research on breast cancer. He was one of the first to challenge the doctrine of radical mastectomy and led the first trial that demonstrated that tamoxifen could increase cure rates for breast cancer victims. He was also the first to describe psychometric instruments to measure quality of life in cancer sufferers. So, Professor Baum, please, the floor is yours.
Thank you very much. Can I share my screen with you? Yes. Right, Professor Pérez, ladies and gentlemen, it's a great privilege to be talking to a group, most of whom I assume are gynecologists. I must emphasize, I'm not a gynecologist, I'm a surgeon, and my title is Emeritus Professor of Surgery and Visiting Professor of Medical Humanities at University College London. I want to start off by showing you this very old photograph, 1948, when I was 11. That gives you an idea that I'm long past my sell-by date. But I'm showing you this family picture just to point out that's my beloved mother, Mary, who died in her late 60s, suffering terribly from metastatic breast cancer. And she'd obviously neglected herself because when the doctors examined her, she had a very advanced breast cancer. This is my little sister, Linda, who was adored by her 4 brothers. And 27 years ago, she found a small lump in her breast and was treated by breast conserving surgery and 5 years of tamoxifen. That was 27 years ago. 2 years ago, she developed metastatic bone disease. Now that should tell you 2 things. One, it's not wise to neglect yourself, having found something in your breast. And secondly, I don't understand breast cancer. If anyone thinks they can explain breast cancer, they simply don't understand it. Because at the moment, there are so many ambiguities, and I will illustrate what I'm talking about. Now, we're going to talk about screening, but there are many types of screening. We're talking about screening by mammography. And the problem all screening are the biases. And if you don't understand the biases of screening, then I can't progress any further. So let me explain the biases. Lead time bias, which prolongs the period of observation. Length bias, which is another way of saying screening is good at detecting good cancers, but the bad ones slip through the net. And attendance bias. The people who accept the invitation for screening are different to the ones who refuse the invitation. Just let me illustrate very quickly lead time bias. Here's an age range. Here is the point at which a woman detects her breast cancer, and let's say that's her time of death. The initial frame for duration of life is that. But look what happens if you expand the frame and include, as a result of screening, finding it, quote, early, but the patient still dies at the same time. So this time zone is the lead time bias. So the mere fact that the survival is longer does not mean mortality is going to be lower. This is length bias. We trawl the sea of womanhood every 2 or 3 years, and we pick up the slow-growing cancers. But in between, the bad cancers pop up. So by definition, screening will always pick up the slow-growing tumors, but may miss the aggressive tumors that pop up between screening. And then the issue of attendance bias. Attenders and non-attenders are different. Non-attenders tend to be lower social class, and stage for stage breast cancer for lower social class has a worse prognosis. And here's an example. 5-year survival in the United Kingdom based on class, affluent and deprived. We don't fully understand it. There are many possible explanations, but that's the fact. Because of those 3 biases, only randomized controlled trials of screening can provide the truth. Observation studies are very misleading. And the outcome measures in these screening trials must be cause-specific mortality, not survival. If you don't know the difference between survival rates and mortality, I'm afraid you won't understand my talk. Secondary endpoints are all-cause mortality, and the importance of all-cause mortality I will come to towards the end of my talk. Now, the hypothetical mathematical model underlying the screening process is a very simple one. You have a linear or log linear progression from duct carcinoma in situ to small node negative invasive cancers, and then to big invasive cancers. So that is the assumption, fundamental assumption for screening. So if you can shift the cancer detection to the left, then inevitably things will get better. And what you should observe is there's an increased detection of early cancers, leading to a fall in the incidence of late cancers. You know, I put them in inverted commas, and I'll explain why they're in inverted commas. More in situ cancer disease detected, less invasive cancer found. Smaller cancers will be detected means that fewer mastectomies and fewer N+ cases, more N- cases means mortality will fall. So that seems to me self-evident and an assumption behind screening. The estimates, the first estimate we got in the UK for the benefit of screening for women under the age of 50 came as a result of the Forrest report. Professor Sir Patrick Forrest, professor of surgery in Edinburgh, a dear friend of mine, he was responsible for this initial report. And his report, from the evidence available at that time, we're talking about 1987, was there would be a 25% reduction in cause-specific mortality, or hazard rate of 0.75. Now, in absolute terms, I don't think anyone listening to me will know what that means. It looks very, very impressive. And at the end of my lecture, you'll understand, in fact, what that means in absolute terms. Now, I was given the responsibility when I was professor of surgery at King's College to set up the first screening unit in the United Kingdom for Southeast England. And that was in Southeast London, which was a very poor area. But my hospital served this area, and it was in a shopping center called Butterfly Walk. So we opened that in 1988. So you'll judge now, I'm obviously prejudiced in favor of screening, because this investment of time and energy to get this going was huge. And I was also at the same time having to care for patients and teach students. And then 1990, it went all over the country. So the National Health Service screening program was launched covering the whole country in 1990. And all the women eligible for screening were sent leaflets, breast screening, the facts, to explain what it all meant, inviting them or coercing them to come. Now, at that time, they were also so believing that this was a good thing. They had special leaflets for women with learning difficulty. Breast screening is for you. Now, many of us found that objectionable, and it took a few years to persuade the National Committee to withdraw the somewhat insulting promotion of screening. Now, I want to show you the early results, the first 10 years of my experience screening in Southeast London. So first of all, what about the detection of duct carcinoma in situ? Well, these are the age groups not screened, over 64, below 50, and this block in the middle were screened, and whoops, shoots up from less than 1% up to 20% of all the cancers detected. So, okay, that's good. We've found lots of in situ cancers, so we can look forward to finding much fewer invasive cancers. So that points at national coverage. Right, so invasive cancer detection, the same appearance, under 50, over 64, and we expected to see a steep fall in invasive cancers. Except we didn't. We found a steep increase in invasive cancers. And we were not alone. We were the first to report it, that instead of reducing the incidence of breast cancer, screening increased it by 30%. And I used to say ironically, the easiest way of reducing breast cancer incidence by 30% was to stop screening. And there are many, many other studies that showed at the point of screening, here, this is the age group being screened, over 50, below 64. Once you start screening, it shoots up. The incidence shoots up by about 30%. Then, okay, all the cases of duct carcinoma in situ, very early cancers, you will expect the mastectomy rate to fall. It didn't. The mastectomy rates went up. They did not fall. And the reason for that was duct carcinoma in situ is often multifocal. Now, it wasn't just us in Southeast London who found this. This study came from Professor Michael Dixon in Edinburgh, and this was the experience in Scotland. The number of cases over this decade for in situ cancer went up, and along with that, the number of mastectomies went up. So again, that was counterintuitive. People with open minds, academics, who, when the data changes, your mind should change, started to get wise to this about 15 years. Well, this paper was a very important paper by Gil Welch, was published in the New England Journal in 2010. And I want you to look at this table that described experience in America, summarizing benefits and harms, imagining 2,500 women over the age of 50 over a 10-year period. About 100 women would have false alarms. Breast cancer will be overdiagnosed in 5 out of 15. That's about 30% of cases. And these women will be exposed to radiation, chemotherapy, and surgery. So this is what Professor Amos was saying the increased incidence, the overdiagnosis that is a consequence of mammographic screening. Well, then all these data started to emerge about 10, 12 years ago, and all the journals were full of it. US panel finds insufficient evidence to support screening. Independent panel opens debate of mammography, and so on. And it was all over the scientific papers, and it was all over the newspapers. And here I want to show you two newspapers, the Times and the Daily Mail. This is the Times, and their headline was, "Keep having scans despite the downside." And three women here, three anecdotes saying, "Screening saved my life." How they knew that, I don't understand. So that was the Times. And this was the Daily Mail. At the same time, we're looking at the year 2002, to screen or not to screen. And that was written by me. For every woman saved from breast cancer screening, 3 endure unnecessary treatment. And here's one expert calls for greater caution. I could only get one anecdote. The Times writer got 3 anecdotes, but I only got one anecdote. And this poor woman explained a common experience. Doctors railroaded me into needlessly mutilating my body. She was very angry to have breast cancer caught very, very early, in situ cancer, not invasive cancer, and yet she ended up having a mastectomy. So what's the downside of screening? False alarms, overdiagnosis, unnecessary surgery, increase in mastectomy rate. Let's look again at overdiagnosis. This is a typical picture of a carcinoma in situ. And in the Cochrane report, which was even worse than described in the New England Journal paper, they deduced from studying 600,000 women in trials that for every breast cancer death avoided, there were 10 women overdiagnosed and overtreated. And that meant that these supposedly precursor cancers are not programmed to progress into an invasive cancer automatically. Most do not. And the toxicity of radiotherapy is significant. My group, amongst other groups, were able to show from clinical trials of radiotherapy there's a significant mortality from ischemic heart disease and also lung cancer. So not small numbers, significant numbers. And this is a very important paper in the Lancet in 2005, the effect of radiotherapy and differences in the extent of surgery for localized 15-year survival. And this is one of many papers that picked up excess mortality from non-breast cancer cases. In the end, 2013, as far as I was concerned, the British Medical Journal invited me to write a paper to try and weigh up the benefits and harms. And I concluded that the harms from breast cancer screening outweighed the benefits if you consider the deaths caused by the overtreatment of overdiagnosed cases. So going back to screening theory, catch it early, save a life, save a breast. The increased detection of DCIS leading to a fall in the incidence of invasive cancer, false. Increased detection of N0 cancers leading to a fall in N1 cancers, false. Increased detection of small lesions confined to one sector of the breast, false. These were all predictions which are false. And as scientists, I'm sure everyone listening to me is a clinical scientist, would agree that if the data changes, your mind must change. You can't go on believing things which are being falsified. And here is a summing up of the data from the Harding Center of Risk Literacy, completely independent. If you screen 1,000 women at the age of 50 for 10 or 11 years, then 5 without screening will die of breast cancer, 4 with screening will die of breast cancer. Now, look at that, 4 versus 5. That is 20% lower. So when people talk about a 20% reduction in deaths from breast cancer, we're really talking about the difference between 4 or 5 amongst 1,000 women over a 10-year period. Yes, it is a 20% in relative terms, but in absolute terms, it's 1, against which you can demonstrate no evidence in deaths from other cancers, and 100 women there have false alarms, and 5 cases in this particular example will be overdiagnosed. Now, showing this again as an infographic this way, 1,000 women without screening, 1,000 women with screening. This is infographics. This is the incidence of breast cancer in red. Without screening, 5 deaths. With screening, 4 deaths. That's a 20% reduction in breast cancer mortality. But then all these green dots are the false alarms, and all those blue dots are cases that are considered to be over-diagnosis and submitted to the problems of over-treatment. So, how can you explain all this? And I'm saying if people think they can explain breast cancer, they don't truly understand it. So many of us, people like me who have become very skeptical, are trying to figure out an understanding of breast cancer that can explain all these counterintuitive observations. Let's look again at the mathematical model that we believe justifies screening, and explain why we think it is false. Well, it is likely many cases of DCIS will regress or remain stable. Otherwise, how come we find 20% increase? Maybe a few will remain latent. Maybe a few will progress. And maybe very small invasive cancers are not programmed to progress, and few might. So what we're talking about is a nonlinear system. And you can only explain these nonlinear systems by a different kind of mathematics called chaos theory. Now, to try and help you understand chaos theory, we are familiar with it at every day of the week when we are put it on our television at the beginning or the end of the news. We have the weather forecast. Weather used to be totally unpredictable, and we get better and better now at understanding weather and even climate, because we are applying a different kind of mathematics. Weather does not behave like this. Little clouds do not necessarily grow into big clouds. We now know that certain clouds will not progress, whereas cumulus nimbus clouds will progress. And so we have good weather and bad weather, but this isn't because small clouds become big clouds. There is a very complex system of climate and weather. And we think people like me, and there are many such people like me now, think we're using the wrong mathematics. We now have to model breast cancer and understand it better by using chaos theory. I'd like to finish with these wise words of H.L. Mencken. For every complex problem, there is an answer that is clear, simple, and wrong. Ladies and gentlemen, breast cancer is a complex problem. Screening is a simple answer. And to me, it is wrong. And it's time we start taking down screening units and using the money that we're wasting on mammographic screening to help women's health in general. You are mostly gynecologists. Many of you are interested and will be learning about hormone replacement therapy. I really wish all the money we're throwing at screening for breast cancer, which does no good, is used instead to look at the totality of women's health and not be obsessed by a single disease. Breast cancer has fallen down the league of mortality to number 7, whereas the top are ischemic heart disease and strokes. Thank you very much for tolerating my heresy.
Okay, thank you. Really, I would say an unorthodox approach, probably by most of the people that listen to this lecture. Questions, I'm sure there will be a lot, but we will keep the questions until the end of the webinar. And now for the second talk by Professor Petra Stute, and she will talk about menopausal hormone therapy and breast cancer risk. Professor Stute is head of Menopause Clinic and Gynecological Endocrinology, deputy head of Gynecological Endocrinology and Reproductive Medicine Section, Department of Obstetrics and Gynecology at the Inselspital. It's a university hospital for women in Bern, in Switzerland. She is the current president of the Swiss Society of Gynecological Endocrinology and Menopause, and of the Swiss Society of Applied Clinical Biochemistry. She is also board member and treasurer of the German Menopause Society. Next slide. Before the slide of Petra, I would like just to show one slide that actually will be the introduction to the lecture. And I would say that the whole scheme started with WGI study. The WGI study showed, among other things, in 2002, the preliminary results show that those women who received estrogen plus progestin had a 26% increased risk for breast cancer. The absolute meaning was 8 more cases per 10,000 women years. So on the one hand, the hazard ratio 26 additional % for breast cancer, it's a significant risk. But on the other hand, I would say it's only 8 additional cases per 10,000 women. So I believe that soon you will hear that the information that we have today is a bit different from what was in 2002 published. And again, Professor Stute will discuss the pros and cons of hormone therapy in this respect. So, Professor Stute, please take the virtual podium.
Yes, thank you very much for the introduction, and I welcome everyone from Switzerland. And it's a pleasure for me to talk about HRT and breast cancer risk. And I decided to have the presentation very close to reality. And so I want to address all the questions that I receive on a daily basis. So that's why I start with case number 1. So let's imagine we have a 52-year-old healthy postmenopausal woman presenting with menopausal symptoms. She doesn't take any medication, she's not smoking, she has a normal body weight, and her family history is empty. So she has several questions for us. And these are probably the same questions you know from your daily practice. So her first question is, what is my risk of breast cancer? Second question, what is my risk of breast cancer while being on HRT? Third question, are there differences between the HRT preparations? And fourth questions, and if I get breast cancer, will I die sooner because I had HRT before? So let's start with the first question, addressing her basic risk of breast cancer based on age. And this is just one example for several tables you will find in several publications. So in this table, we can see the 5-year risk, 10 years risk, and 20 years risk of being diagnosed with breast cancer. In our situation, our patient is between 50 and 54 years old. So her 5 years risk is 1.4%, which means that 14 out of 1,000 women aged 50 to 54 will be diagnosed with breast cancer within the next 5 years. So that's her age-dependent baseline risk for breast cancer. So her second question is, what is my risk of breast cancer if I start HRT? So I went back to the literature and found an umbrella review just published a few weeks ago. So this is a systematic literature search until December last year. And this search included all systematic reviews, meta-analysis, RCTs, observational studies on the impact of HRT on breast cancer morbidity, breast cancer mortality, and all-cause mortality in peri- and postmenopausal women, among other endpoints. These authors found 60 systematic reviews, 102 meta-analyses from RCTs, and 38 meta-analyses from observational studies. And here are the results. So they calculated the relative risk to be diagnosed with breast cancer in estrogen, progestogen users and estrogen-only users. So, but if you have a closer look, you will see that they only included case control and cohort study, and they calculated an increased relative risk of 1.4 and 1.16 respectively. So they did not include RCTs, and they did not provide data on risk addressing treatment duration. So then I decided I have to go back to our guideline from the German-speaking countries, which we published just last year. And here we can see again numbers, absolute numbers, for women using estrogens alone or estrogen combined with progestogen. And in this guideline, we differentiated between RCTs and observational studies. And now I would like to focus on the RCTs. And here we can see for current estrogen users that their risk of being diagnosed with breast cancer is decreased. And in absolute numbers, there will be 4 fewer women in 1,000 postmenopausal women using estrogen only for 7.5 years compared to non-users. In contrast, women using estrogen combined with progestogen, the RTCs showed that there will be 5 additional cases per 1,000 postmenopausal women being treated with estrogen and progesterone for 7.5 years. Now, the third question of our patient. She's asking us if there are differences between HRT preparations. And usually this question addresses bioidentical hormones. So what are bioidentical hormones again? These are substances that have the same chemical and molecular structure as hormones produced by the human body. And in the context of HRT, we think about estradiol and progesterone. And those hormones will either be available as EMA or FDA approved preparations, or sometimes they are also produced by so-called compounding pharmacies. So what is the impact of so-called bioidentical hormones on breast cancer risk? And 3 years ago, two colleagues of mine and me, we published a systematic review on estrogens combined with micronized progesterone on breast cancer risk. We then identified one meta-analysis on HRT and breast cancer that considered progesterone but not duration of therapy. So the overall conclusion of this meta-analysis was that estrogens combined with progesterone does not increase breast cancer risk. However, duration was not addressed. Then we found the two RCTs, KEEPS and ELITE from the US. These two RCTs have as a primary endpoint cardiovascular endpoints, and breast cancer was only counted as serious adverse event. So after 4 and 5 years respectively, the absolute numbers of breast cancer cases was not higher in the active treatment arm compared to placebo. Now we go to France. Here we have the case-controlled study CECIL that showed no increased breast cancer risk for more than 4 years of HRT with progesterone. So until now, it looks quite fine. But then we still have the prospective cohort study E3N that showed an increased breast cancer risk for more than 8 years of combined HRT with either progesterone or dydrogesterone. And because this is still the only study showing an increased risk, I would like to focus on this one a little bit more. So these are the major results of this study and paper. So what we can see here on the left side is that for women currently using estrogen combined with progesterone or dydrogesterone for up to 5 years, breast cancer risk is not increased. However, if we now look on the right side, we can see that for women using estrogens combined with progesterone or dydrogesterone for more than 5 years, breast cancer risk increases. And in this calculation, it was increased after 8.7 years of treatment. So based on these findings so far, the international guidelines, and so did the German-speaking country guideline, said that women who are considering HRT must be informed that HRT may lead to a slight or even no increase in the risk of breast cancer. The potential increase in the level of risk depends on the composition of the specific HRT and the duration of HRT intake, and decreases after HRT is discontinued. And also in this guideline, we can read that there is some evidence from cohort studies suggesting that continuously combined HRT leads to a higher incidence in risk than sequentially combined HRT. And further on, as I've already mentioned, that there is some evidence that estrogen-progesterone therapy with progesterone or dydrogesterone results in a smaller increase in risk. Still, we have other preparations that might be quite interesting. So the first product is Tibolone. Tibolone was assessed several years ago to find out if Tibolone compared to placebo is able to reduce fracture risk in women with osteoporosis with or without fractures. So in each arm, there were more than 2,200 women. One arm received Tibolone and the other one received placebo. So after almost 3 years of treatment, the study has had to be stopped because the risk of suffering from a stroke was increased. But if you look a little bit closer, the mean age of women was 68 years when they started Tibolone. But apart from fracture risk and stroke risk, there were some intriguing results addressing breast cancer risk. And in this study, Tibolone was associated with a significantly lower risk than in women compared to placebo-treated women. And then some very optimistic calculations started showing that if 1,000 women were treated for 5 years with Tibolone, this would lead to a reduction of 10 cases per 10,000 women treated. However, in this LIFT study, breast cancer, again, was only assessed as a serious adverse event and was not a primary endpoint. Still, there's another very interesting product, which is a TSEC. TSEC stands for Tissue Selective Estrogen Complex, and there's only one product on the market, which is a combination of conjugated equine estrogens and the SERM basedoxifan. And 5 so-called SMART studies have been performed, and they also assessed some breast-related symptoms or also breast cancer incidence. So you can see on this table here that the treatment duration was either 3 months, 1 year, or 2 years. And in these studies, breast pain, breast density, and breast cancer incidence was not different from placebo-treated women. However, the breast cancer risk in TSEC users has not been established because of the small numbers of events and insufficient duration of clinical trials, only up to 2 years. So nevertheless, in a pooled analysis of all 5 SMART trials, the relative risk of breast cancer for the TSEC user was 1.1, and thus similar to that for placebo. Now the 4th question of our patient. So she's asking, and if I get breast cancer, will I die sooner because I had HRT before? And the very short answer is no. So why can I say no? Because just last year, the WHI groups published another analysis showing or giving more detail about the incidence of invasive breast cancer, but also death from breast cancer and death of all causes after having been diagnosed with breast cancer. And in this figure on the upper part, we can see the development or the follow-up for all those women that had received conjugated equine estrogens and MPA compared to placebo. And in the lower part of the graphic, we can see those women that had received estrogens alone. And what you can also see that after having stopped those trials after 5.5 years for the combined treatment or 7.5 years for the estrogen-only treatment, the follow-up is almost now 20 years. And this follow-up did find a significantly lower breast cancer mortality for estrogen-only users, while estrogen progestogen therapy had no effect. And both ET and EPT did not have an impact on all-cause mortality in those women that had been diagnosed with breast cancer. And a similar result was published from a Long Island breast cancer study, which is a population-based cohort study including women with breast cancer matched with women without breast cancer. And a standardized interview was performed, also asking about HRT approximately 3 months after breast cancer diagnosis. So the median follow-up was almost 17.5 years, and the National Death Index was used for assigning time and cause of death. And very shortly on this table, we can see that in women ever having used HRT compared to never user, all-cause mortality and breast cancer mortality was not increased compared to never HRT, but was decreased. So coming back to all these questions our first patient had, we can now answer her in the following way. So when she's asking, what is my breast cancer risk? We can say your 5-year breast cancer risk is 1.4%. And if she wants to know what is my risk of breast cancer on HRT, we can say there will be an approximately extra 5 cases per 1,000 women using combined HRT for 7.5 years. And if there are differences between the HRT preparations, we may say that bioidentical HRT, Tibolone, and TSEC are more breast friendly. And if she's asking if she gets breast cancer, if she dies sooner than if she had taken HRT before, the answer is no. Okay, now we have our second case. So this is a 51-year-old perimenopausal woman presenting with severe vasomotor symptoms. Her mother was diagnosed with breast cancer at the age of 75. She's undecided about HRT because her mother warned her never take hormones, and she wants to know if her mother was right. So let's have a look first on the risk if a woman has 1 or 2 first-degree relatives with breast cancer. And this is the perspective from a 20-year-old woman. And we can see on the first lower line how her breast cancer risk increases with age. And if she now has 1 first-degree relative or 2 first-degree relatives, then we can also see how her risk will increase with increasing age. And very roughly, we can say that if there's 1 first-degree relative with breast cancer, this will roughly double her risk. And if she has 2 first-degree relatives, this will roughly triple her risk. And now we would like to know how the risk develops if we now integrate HRT. And we can, for example, use the risk calculator Amos. And in this risk calculator, you can add all the characteristics of your patients, and then we can calculate the 5-year risk for breast cancer with a positive family history, which in this case is 1.9%. And now you might wonder if this is high or low, and if she can start HRT. This is why we now have a look on this paper here, which helps us to find an answer to this question. And as you can see, these authors differentiate between low, moderate, and high breast cancer risk based on Amos risk stratification. And they say that breast cancer risk is low if the 5-year breast cancer risk is below 3%. And as we've already calculated, our patient would fall into this category. But now you might wonder if this is really true and if we also find these answers in the literature. And this is why we go back to the publication from the WHI from last year. And as the WHI has so many women included, it's possible to do subgroup analysis. And we will focus now on the subgroup analysis for women with or without first-degree relatives with breast cancer. And we will focus on this a little bit more. So in this table, you will see the number of women either treated with conjugated equine estrogens or placebo, or those women treated with either combined HRT or placebo. And we will also see in this first column of the table the answer to the question if there was a first-degree relative with breast cancer, no or yes. Then on the other columns, you will see the number of events, the difference per 10,000 women per year, and the hazard ratio and the p-value. Now let's focus on the p-value first. And then you will see that there is a significant p-value for the question if there is a significant difference for women with or without a first-degree relative with breast cancer. But if we look a little bit closer, we will see that women who do not have a first-degree relative with breast cancer and are treated with estrogens only, they will have a decreased risk of being diagnosed with breast cancer. Whereas women who do have a first-degree relative with breast cancer and they receive estrogens only, then their risk is not increased. So this is the difference between those women with or without a first-degree relative with breast cancer. If we now have a look at women treated with combined HRT, and if we differentiate then for women with or without first-degree relative with breast cancer, there's no significant difference between those two groups. So we can say to this woman at this point that studies to date show no additional increase in breast cancer risk in women in those women with family breast cancer. Third case. Now we have a 30-year-old BRCA1 mutation carrier with a negative personal history for breast cancer or ovarian cancer, and who has completed family planning and is now considering having a prophylactic bilateral adnexectomy. The memories remain intact. That means no prophylactic mastectomy is performed. And she asks, can I take HRT? And if so, how long? So now here we have the meta-analysis from 2018 investigating the impact of HRT in women that have been in whom a bilateral adnexectomy has been performed. All of them were BRCA mutation carriers, and all of them had intact mammae. So what we can see here is that we have 3 studies, and the biggest one comes from Kotsopoulos, which included 872 women. They were all BRCA1 mutation carriers. They could decide if they wanted to take HRT or not. HRT duration was almost 4 years and follow-up was 7.5 years. So the main result from this meta-analysis was that HRT did not have an impact on breast cancer risk if a woman had received prophylactic bilateral adnexectomy, but still had her breast tissue. So the biggest study, that one from Kotsopoulos from 2018, was big enough to differentiate between estrogen only and estrogen progestogen treated women. And they found that estrogen only therapy was associated with a lower risk of breast cancer than estrogen progestogen therapy. So quite the same story as we have it in non-BRCA mutation carriers. And if she takes HRT, how long is it possible? And now we have a look at the British Menopause Society's consensus statement. And here we can read that the current recommendation is that after risk-reducing BSO, add back HRT is used until the age of an expected natural menopause, which is in our case, the answer. If we get the question, if she can take HRT, we can say yes. And if she asks for how long, we could say, based on the British Menopause Society statement, until 51 years, which is the average age of menopause. Now I come to the last patient. This is a 54-year-old patient with breast cancer and who complains about menopausal symptoms, including vaginal atrophy. And she asks, can I use HRT or vaginal estrogen therapy? And about the systemic HRT, the international guidelines are quite clear. So we can read everywhere that HRT is contraindicated in women that have been treated for breast cancer. And this we can find in the German-speaking guideline, but also, of course, in the North American, which was published in 2017. However, if we now ask about vaginal estrogen therapy, we can read in several guidelines and also in the German-speaking country that an off-label treatment with ultra-low dose vaginal estriol, which equals 30 micrograms 3 times weekly, seems to be justifiable. Nevertheless, should first non-hormonal alternatives be used. And then in some countries, we also have vaginal DHEA. And the question is, what about this product? If we now go to the legal situation, then we will see that in Europe and Switzerland, vaginal DHEA is contraindicated in breast cancer survivors. However, in Canada and also in the US, there's no contraindication for vaginal DHEA in breast cancer survivors. And there's already one retrospective cohort study showing that vaginal DHEA applied in breast cancer survivors once daily for 1 year does not increase breast cancer recurrence risk. However, this is only, of course, a short follow-up. And because it's not contraindicated in the US, the American Society of Clinical Oncology states that vaginal DHEA can be recommended for women with current or a history of breast cancer who are on aromatase inhibitors and have not responded to previous treatment. Coming to the conclusion, As you all know, individual breast cancer risk is affected by modifiable and non-modifiable risk factors. Combined HRT increases breast cancer risk depending on the progestogen type and treatment duration. Estrogens only, Tibolone, TSEC, and bioidentical HRT seem to be more breast-friendly. Systemic HRT is officially contraindicated in breast cancer survivors, while vaginal estrogens and DHEA can be applied off-label in breast cancer survivors. Thank you very much.
Thank you. And now I think we will have some time for questions. There are a lot of questions, but first of all, I see that some participants just wanted to say thank you for both speakers for the nice and very impressive talks. And I have to, can you hear me now?
Yes, we can hear you, but we can't see you. No.
Can you hear me?
Yes, now hearing and
Okay.
seeing. Good.
So now some of the questions tell me actually that in such presentations we cannot get into details. And some of the questions want the speakers to get into details, which is impossible. But there are some general, more generalized questions. The first one is for Michael. Professor Baum, the impression from your presentation is, of course, that probably screening is not needed, is not justified. But what do you say about self-examination by women and breast examination by the physician? This is not mammography. Would you say it should go on? And the second question is whether or not we still have screening, but look for the high-risk population rather than generalized population. Please.
Those are very good questions and need to be addressed. I didn't have time in my talk to cover those. Now, as far as breast self-examination is concerned, the evidence we have, there have been 3 very large trials which show that there is no impact in breast cancer mortality from breast self-examination, but there is a downside in that there are twice as many false alarms and biopsies. So breast self-examination, as you see it all over the women's magazines, so examine yourself, save your life, it doesn't work. It simply doesn't work. I can't say anything more than that. Many people say it should work, but I should be rich, but I'm not. And BSC should work, but it doesn't. Now, clinical breast examination, I think that there's a very big Indian trial going out to the countryside outside of Mumbai. It was organized by my friends at the Tata Memorial Hospital. When you're dealing with that kind of a population, very poor population living in villages, it is advantageous. But in Western wealthy countries, I'm unaware of clinical trials of CBE. I may be wrong, and if anyone knows one, please, I'd be very interested to know about it. The third question is critical. I've been advocating this for a long time. As things stand, there is, as far as I'm concerned, there is no net benefit. It's a zero-sum game. For every breast cancer death avoided, you have a death from another cause. But there may be a case for risk adaptive. And I've been advocating that we do clinical trials for risk adaptive. I'm no longer in a position of authority. I no longer have an academic unit. I'm active in theory, but I don't have a department that can set up such a study. And I think that's a very good question, and I would like to see. I suspect that there is a subgroup who may benefit. How we define that subgroup, I'm not sure. Even BRCA1 mutation women, you think screening might be advantageous for them. There's not been a clinical trial. There have been observational studies that suggest MRI shows more cancers than mammography, but that isn't the question. The question is, does it actually save lives? And we don't know. But thank you for those critical questions that I'm very happy to express an opinion.
Thank you. And now for Professor Stute. People ask, of course, and we know that this is a very important point. How do you actually weigh? One hand is all the warnings about HRT. On the second hand, women suffer. The symptoms sometimes lead to very poor quality of life. So where is the red zone, let's say? You cannot ignore the symptoms. How do you, in your clinic, how do you weigh the symptoms against maybe the warnings?
Okay, so if a patient comes for a first consultation, asks about HRT, I usually ask her to tell me what is her number 1, 2, 3, and so on priority, which should be better. So, and usually these are symptoms like hot flashes, night sweats, and to prevent weight gain and so on. And then I discuss with them the pros and cons of HRT. Then I have a huge probe list, which is not only symptom-based, but also fracture risk reduction. And if they are below age 60, the benefit for the heart, the benefit for the brain, and also a positive impact on diabetes prevention, colon cancer prevention, and so on. So the pro list is quite long. On the con side, we have breast cancer, obviously, but only for the combined therapy. And we have the thromboembolism risk, which we can easily get rid of by using transdermal estrogens. And then it's usually, and then I give them exactly the numbers I presented in my presentation. And then I will tell them, we first will look if we are able to get rid of the symptoms that are on your wish list. And usually we will see the results in quite a few weeks or months. And we do not have to decide today for how long you will take HRT. We first have to see if we can fulfill your wish list. And if we fulfill your wish list, then we will continue, and then we will meet once a year to discuss again about the pros and cons and how we should proceed. So that's how I do it on my daily basis. Good.
Another question that I expected to come was, of course, we talk about HRT, but HRT is a large group of preparations and dosages and the mode of treatment, local treatment, vaginal treatment, by implant or by a pill or whatever. So I think that everyone should understand, and please tell us what is your opinion, that the lecture was very general, and we should pick the right preparation for the right symptom, the right dosage, the right timing, age, and everything is calculated, which is not so easy.
Yeah, so in this presentation, obviously, I focused on systemic HRT because for vaginal estrogens, there is no indication that it would increase breast cancer risk. So the focus is only on systemic. And then And the main difference is between estrogens and estrogen combined with progestogens. And the dosage of estrogens depends how effective it is for treatment, for treatment of the symptoms. But and for breast cancer, there's no difference if you take it transdermally or orally. So that's important for cardiovascular events, but that's not important for breast cancer consultation. And that's why I actually tried to give an overview that that HRT is not HRT, because we have the estrogens alone in several different dosages. We have estrogens combined with progestogens. Then it depends on what kind of progestogen you take. So that's why I differentiated between the synthetic progestogens compared to dihydrogesterone or micronized progesterone as a partner for the estrogen. And then I also focused on Tibolone. That's it's a synthetic steroid and sometimes a little bit forgotten, but still it's one HRT product that we can use and which does not have a negative impact on breast tissue. And then also the TSEC, which we do not have available in Switzerland, unfortunately, but in the US it's available, and so far it seems to be neutral for the breast. So I tried to differentiate between the different approaches we can choose if we want to treat someone with HRT. But of course, I cannot go into every synthetic progestogen in combination with an estrogen.
Thank you. And the question back to Professor Baum. Among your research, I think, there are some psychological issues in breast cancer patients. And I wonder whether the change in the screening programs, what would be your opinion about fears? Let's say a woman at the age of 50 or 60, the health system would say, you don't need screening. But then there could be fears that maybe I have cancer. I have to do the mammography because until now everyone was doing mammography. How would I know that I'm okay? On the other hand, the overdiagnosis and the fears that I have some lump in mammography that was diagnosed as not a cancer also produces fears. So what would you say about that?
So the question is what I said to a woman to whom I do not recommend mammogram screening. Is that correct? If she's afraid?
No, sorry, I asked Professor Baum, and then you will, and then I'll give you also.
Okay.
Okay, please.
Yeah.
Just before I answer that question, I want to thank Professor Stute. I enjoyed her talk so much more than I enjoyed my talk.
I think there will be a but.
There's no but at all. You reinforce all my prejudices. And when I was doing, not long ago, up until I fully retired, I was having to deal with lots of frightened patients with breast cancer and dealing with the problem of HRT. And the first thing I would say, that there's a kind of myth that estrogen causes breast cancer. I don't know where that comes from. It's the opposite. All the evidence suggests that estrogen protects against breast cancer, and that what we're dealing with is estrogen deficiency syndrome. And if you've got a thyroid deficiency or steroid deficiency, you replace the hormones. So I just want to thank you as a non-gynecologist. But in answer to the other question, I value those questions. You mentioned in my CV, for 7 years actually, I chaired the psychosocial committee on cancer in the United Kingdom. And this was a subject very close to my heart. Along the way, we developed a number of psychometric tests so that we could quantify what interventions reduced or increased the anxiety and depression. And the sexuality issue comes into it at all. And the problem is so many, there's so many counter views. My bottom line is that the women should be treated as intelligent adults, more intelligent and adult than most men, and educated to make informed decisions. So my default position here is to provide women with enough information to make an informed choice. So it's a question of informed choice. Now, they can only make informed choices if they're informed. And I spent a lot of my time, my career, developing aids for informing women. And 2 years ago, I wrote a book, The History and Mystery of Breast Cancer, for women to inform them. So when these difficult issues develop, they make an informed decision. And I'm sure if given time, any of those scenarios you mentioned, having mammogram, not having mammogram, if I just spent 15 minutes with such a woman, I could palliate her anxiety and allow her to make an informed decision. So I appreciate the question. And when breast cancer is concerned, there's so much misunderstanding and so much unnecessary fear that all us professionals have a responsibility to do something about that.
Professor Stute, you wanted also to comment? No, so I have maybe the last question because the time is almost up, and it's for both of you. So for Professor Stute, why actually can't we convince the regulators that HRT could be safe? Is it possible? And then I will ask the same question, not the same, but almost the same question for Professor Baum. Is there any chance that the regulators will be convinced, or the ministries of health, to stop the conventional screening mammographies? Is it possible? So first, Professor Stute.
Yes, of course, it would be great if we were somehow able to convince the regulatory authorities to change the package inserts, but I'm pretty sure they want us to do tons of randomized controlled trials for probably ages and to show no harm, and then they might think about changing the insert of the packages. So I think this is going to be very difficult, and I still believe that so many people, or also the regulatory authorities are so afraid that something like we had with the WHI at the beginning of 2002 could happen again, that they are still very restrictive. However, the international guidelines are not so restrictive. And so the question for me is more, how can we convince our colleagues and also our patients to see the pros and cons of HRT in a more realistic way? So I think we will have to do more efforts still in communication also to our colleagues.
Good, thank you. And now for you, Professor Baum.
It's a good question, a very important question, and it comes down to politics. Amongst the cognoscenti in this subject, there is a consensus that screening doesn't live up to its promises. I'm not a heretic. I'm not a maverick. People like to say I'm a heretic, a maverick. I'm not. It's what I'm saying is common parlance. The issue is politics. I several years ago was invited to address the all-party committee on health in the House of Commons. And I told them all this. And then you think they're fools, they're not. Particularly the ones who attend the health committee. They're very knowledgeable, and they agreed with me. They accepted what I said, but then said afterwards, but politically it might be suicide. So you can imagine, we've got pretty much a two-party system. Both sides of the House, the Conservatives and the Labour, they're both a bunch of dysfunctional people. I'm almost feel, maybe it's worth in Israel where you've got 15 parties, but we essentially have 2.5 parties if you consider the Liberals. But whichever side of the politics said we should stop screening, the other side would have marching up and down. Look at them, they're withdrawing screening from women, you know, they're killing women. And it's political. So I've come to the conclusion that we should inform the women, forget about the politicians, and let the women decide. And I've got many, many influential women who agree and are beginning to campaign amongst women. Forget the politicians, you'll never persuade them.
Great. So I think time is up and we need to conclude. I really thank the speakers. I think that all of us now have a lot to think about, and maybe I don't know if it's possible, but by the IMS, maybe you could send us your remarks or comments. There were more than 40 questions, and unfortunately we couldn't bring them up because of lack of time. However, please keep getting into the IMS webinars, and a special thank for whoever were the participants from China.